Welcome. Let's study together. Why? Well, it's easier and more fun. You'll be more efficient. Repetition is the key, and we'll be doing this a lot. And you'll get some free study notes. How are we going to do this? Well, we're going to have 5 questions per block. I don't want to make the blocks too long, so 15 to 20 minutes per each. There's no computer reading, so you'll be enjoying my pretty accent. There's no fancy formatting, simply because you're not going to have any on your exam, so make sure you get used to the white background. You're going to have 5 seconds per each question to pause, read, and answer, so make sure you do pause. And then we're going to talk about the correct and incorrect answers. Alright, at the end of each block, you're going to find study notes. They're awesome, so be ready for the screenshots. And guys, please, if you have more questions, make sure that you do pause them. Okay, I'll get to them, I promise. Here we go. Make sure you pause. I'll give you 5 seconds per question. So these are the correct answers. Let's talk about them. Okay, so this question wants us to single out the least likely symptom with osteoarthritis. Okay, so let's see, what are the symptoms of OA? So they include pain, tenderness, limitation of motion, instability, bone swelling, and joint deformity. Okay, so when it comes to pain, pain in OA is worse with joint use, and it's relieved by rest. Okay, so there we go. So morning stiffness lasts usually less than 1 hour. Okay, and we have tenderness. So there is tenderness, but there's little or no swelling at all. That's because osteoarthritis generally does not have an inflammatory component except in advanced disease. So that's why this is the correct answer. Okay, it's least likely to be found in OA. Then, of course, there's a limitation of motion. When it comes to instability, we're going to most likely see giving away or buckling in knee OA. When it comes to bone swelling, it reflects remodeling of the bone and cartilage on either side of the joint, and then marginal osteophytes may be evident. These marginal osteophytes are nothing but the bone spurs. So keep in mind that plain x-rays are the most widely used still to diagnose OA, and then the characteristic features can be seen, which are marginal osteophytes or bone spurs, then joint space narrowing, subchondral sclerosis, and cysts. So let's take a look at So that's about the bone swelling. Joint deformity is a sign of advanced joint damage. It is especially seen in hands, and therefore we can appreciate Hebridean's nodes and Bouchard nodes. Now let's take a look at Okay, so let's take a look at this photo here so we can appreciate Hebridean's nodes in DIP joints and Bouchard nodes. They're bony swellings that can develop in PIPs. So you can see here, these are all DIPs. Okay, so that's Hebridean node. And then here is a PIP, and that's a Bouchard node. Okay, therefore, these are all incorrect because they're all seen in osteoarthritis. Let's get to question number 2, which is asking what not to use in the treatment of acute gout. So acute gout or gout flare is an intensely painful and disabling inflammatory arthritis. It usually involves single joints such as big toe, but occasionally involves 2 or more joints. So how to treat it? Okay. So in addition to increased fluid intake, there are several therapies that are effective for the treatment of gout flares. They include glucocorticoids. Okay, they can be systemic or intra-articular. NSAIDs, such as naproxen or indomethacin. And there's colchicine. Okay, make sure you memorize this. It's a must to know for your exam. And then it's easy, right? If you know these 4 points, then you're going to be able to exclude the other 4 and stay with this one. Okay? So therapy to control the underlying hyperuricemia is contraindicated until the acute attack is controlled, unless the kidneys are at risk because of an unusually heavy uric acid load. So starting therapy to control the hyperuricemia during an acute attack may actually intensify and prolong the attack. Therefore, allopurinol should not be used in acute attack, which is, by the way, used to reduce the generation of uric acid. They could ask you another question about another medication, okay? So on this list, you may find aspirin instead of allopurinol. So aspirin should not be used to treat acute gout. Let's get to question number 3. So we have a 2-step, or actually a 3-step question. We have to figure out the initial diagnosis, the current diagnosis, and the treatment for it. So the topic is postpartum pyrexia. When it comes to this, we have to think about several different conditions, and these include surgical site infection, endometritis, UTI, septic pelvic thrombophlebitis, C. difficile infection, and drug fever. So initially, this patient has fever, uterine tenderness, and we're going to think about endometritis right away. It has fever, uterine tenderness, and minimal abdominal findings. So we're going to use the broad-spectrum antibiotics. Okay? Well, nowadays we usually use clindamycin plus gentamicin, or we can actually use piperacillin plus tazobactam. All right. Now, the patient comes back with fever, despite the use of antibiotics, at 7 days postpartum. think of septic pelvic thrombophlebitis. It's associated with persistent fever and normal abdominal and pelvic findings. What do we treat it with? We use IV heparin for 7 to 10 days. Okay. All other possible answers just don't make much sense once we figure out the diagnosis. There's no reason to cover for fungi. Continuing antibiotics with an increased dose won't fix this. DNC and hysterectomy, that would be just too aggressive and needless to treat this patient's diagnosis. Let's go to question number 4. Okay, so this question is dealing with primary immunodeficiency, so we can exclude these two right away. So it's quite a straightforward question, and you must know this for your exam. So make sure you memorize this. In any patient who develops anaphylaxis after immunoglobulin exposure, you have to think about IgA deficiency. That's a must. In other words, if you know that a patient has IgA deficiency, do not give him or her immunoglobulins because it can cause an anaphylaxis, which is caused by anti-IgA antibodies. To diagnose it, look for recurrent respiratory and GI infections, a low IgA level, and IgG subclass 2 may be low as well. Now, how to exclude these two? So severe combined immunodeficiency usually presents in the first months of life, and classically you're going to see recurrent severe infections, chronic diarrhea, and failure to thrive. And DiGeorge syndrome, is associated with hypocalcemia and tetany in the first 2 days of life. And you also have to look for absent hypo or hypoplastic thymus, congenital heart defects, and typical phases. And they're very susceptible to fungal and viral infections. So that's a safe way to exclude these two. And memorize the Ig deficiency and immunoglobulins do not go together. And question number 5. Let's see what we got here. It's an obese woman with C-section because of dystocia, and the baby is quite big. So let's talk about dystocia first, just for a bit. It's an abnormal progression of labor or a failure to progress. It's the most common cause it's the most common reason for primary C-section, and it's not that uncommon at all. Actually, about 20% of all labors ending in a live birth involve an arrest disorder. And there's one thing that you absolutely need to remember for this, is that labor augmentation is contraindicated in this setting. Okay? Absolute no. Okay, now what about the size of the baby? 4,700 grams is quite big for a baby after 37-week pregnancy, okay? So this is definitely large for gestational age newborn. The common causes include maternal DM, racial and familiar factors, increased parity, previous LGA infant, high BMI, large pregnancy weight, and certain syndromes. And we can certainly say if the patient had routine prenatal care, she could have been screened, diagnosed, and properly treated. So this could have been prevented. Therefore, the correct answer is definitely A. Now, preeclampsia is associated with actually small for gestational age. Now see, this could have been correct if we didn't have the information about obesity or the infant size, because the most common cause of failure to progress is cephalopelvic disproportion. And D can be excluded because the birth weight of children with Down syndrome is slightly less than the birth weight of their siblings. So since there's no any difference, we can't say that the infant likely has Down syndrome. Okay? The infant and the diet is a definite no. And that should be it. Okay, let's sum it up. Get ready for the screenshots. Small for gestational age and large for gestational age. Good job, guys. Thank you for studying together. Let's go on to the next block.